So my name is Jennifer, I'm one of the surgical registrars.
I'm Sumit. Good evening, everyone. I'm the surgical registrar.
And our quality improvement project was about patients presenting with iliac fossa pain. So what was the problem? So probably most of you aren't surgeons, so you don't know, but there's been a national audit called Getting It Right First Time, which was an audit done across the country in various surgical specialities, looking at various quality indicators. And one of the things that the audit focused on in general surgery was appendicectomies, because it's such a common operation. Two of the quality indicators that they looked at in that audit were the rate of negative appendicectomies. So that is an appendix which is taken out at surgery, and then when it's looked under the microscope, it doesn't show any signs of inflammation. So it's essentially the patients had their appendix taken out unnecessarily. The other indicator that they looked at was the length of stay in patients that are admitted for an appendicectomy, and they looked at the length of stay nationally, and what they found was that there was a lot of variance across the country. So this was particularly relevant to Northampton, because here in Northampton our negative appendicectomy rate is 35%, which is the highest in the country. So to put that in context, over a third of patients are having their appendix taken out unnecessarily in this hospital. And in terms of length of stay, our average length of stay is 3.4 days for patients that come in with appendicitis. Nationally, how that compares is that there are over half of trusts that are able to discharge their appendicectomy patients in less than 2 days. So that's quite a significant difference given all our winter bread pressures, etc. So the two main issues that we were looking at were our negative appendicectomy rates, how we can reduce these, and our length of stay for patients that are admitted for appendicectomies.
So at present, what happens is emergency patient to general surgery with right iliac fossa pain can present either via ambulatory care pathway, which has got 12 hours access Monday to Sunday, 7 days a week, or via A&E, 24 hours access. So they are significant proportion of the patients we see in emergency. There are about 250 in average per month, and half of them get admitted, about 126 to be precise. That's in average, and that is almost 4 a day. So there are a significant number of patients that come to in with this problem. We thought of streamlining this. So at present, what happens is they get seen, assessed initially by a junior doctor or frontline staff. They get reviewed by a surgical registrar or consultant with full set of blood tests, urine test, and full clinical examination. Then those who are clear-cut, clinically diagnosed as appendicitis get admitted, get their operation done as an emergency procedure. Quite significant proportion of them we are not 100% sure, or they've got atypical features, and it's not easy to manage those patients. At present, quite a few of them are getting admitted as inpatients, and they get some sort of imaging, whether an ultrasound scan or CT scan, next day morning if we are lucky, or maybe the day next, and they may get operated. Again, there is significant delay. All this adds up to the length of stay eventually, and sometimes unnecessary admissions.
So we thought about how we can improve these two issues, so decreasing our negative appendicectomy rate and reducing our length of stay. So just concentrating on reducing our negative appendicectomy rate. So how can we improve this? Well, typically or traditionally, appendicitis has been a clinical diagnosis, but we know that imaging improves the sensitivity or pickup rate. And there's two ways you can do this: ultrasound scan, which has its advantages, or a CT scan. Ultrasound typically has a sensitivity rate of about 78% and CT of 90%. But ultrasound is more readily available, so we tend to use that first. And we know from talking to trusts regionally and nationally that they have a much lower threshold for imaging patients before they go to theatre, which probably goes part way to explaining why they have a lower negative appendicectomy rate than we do. So that was the first part of the problem. How can we incorporate more imaging into our diagnosis, or to aid our diagnosis, and how quickly and readily available would this be? The second issue was to reduce our length of stay. And what we do currently with abscesses that come under general surgery is if there's no theatre availability on the day that they come in, they go home overnight and then come in through our main theatre admissions unit the following day for their planned surgery. So we had a bit of a problem. It was how to get imaging without increasing the length of stay. So, as Sumit said previously, often the patients will end up coming into hospital, being admitted to allow us to image them, because we don't have the facility as it stands to image them as outpatients. So we had a lengthy discussion with radiology, lots of toing and froing, and what we wanted to do was to have increased availability for ultrasounds and CT scans through our hot clinic, which runs currently for patients that we suspect have biliary colic.
So with all this in mind and with the given background, we came up with this flow chart where in the middle it shows the adult patients can either present via ED or ambulatory care pathway. So then they get senior review and get divided into two major components. One is a clear-cut diagnosis of appendicitis. They need an operation. Now, operation for someone who's really unwell, tachycardic and scoring high on EWS score, they need an appendicectomy same day. They get admitted, IV antibiotics, and we get them operated as soon as we possibly can. But there are some patients on this side of the pathway where they are reasonably well. We've diagnosed them with appendicitis. They would perhaps need an operation, but there may be some inevitable delay. Like, for example, they've just had food, so they have to wait for 6 hours, or the theatres are really busy. So they can do with going away the same night and coming back to MTAU, as Jenny suggested, the next day as a sort of a semi-planned operation, and hence we avoided unnecessary admission overnight. But the chunk of patients who will get benefited from this is those who with atypical features. We are unclear about the diagnosis. And as Jenny said, we wanted some sort of urgent imaging, not really outpatient, but not at the same time, because we are struggling with resources. So we wanted a next day hot clinic ultrasound scan where they come up with a scheduled appointment or a CT scan as thought appropriately depending upon various factors, and get reviewed in hot clinic and thereafter manage appropriately, whether they need an operation, whether they need referral to another specialty or something else. So we're lucky to have negotiated 3 ultrasound slots and 2 CT scan slots for our patients in general surgery. Now there will be that middle path where we are unsure about the patient and they have to be admitted because they may need some investigations as inpatients. So they will be far less than what we are doing now. And the other chunk of patients that will benefit, if you go next please, is those who are well patient can go home and come back next day. At least we reduce the length of stay. And they can sleep in their own bed and be comfortable, be more prepared for surgery rather than being rushed. So that's it.
So where are we now? Things definitely took longer than we anticipated getting them into place. We learnt lots along the way. We learnt how many stakeholders were involved in what seemed like a relatively simple process to implement. But actually, once we sat down and drafted the initial flowchart, we realised there were so many people to consult, and everyone wanted their opinion putting in, and we must have drafted about 20 flowcharts before we actually got to the one that's on the presentation. So I think we also kind of had to, initially this project started off as just reducing the length of stay, but once we realised that, we looked into the data and realised that coinciding with this was our negative appendicectomy rate, we realised it made sense to incorporate 2 projects into one, because one probably wouldn't work without the other. So it's actually turned out to be a much bigger project than we anticipated. But I think everyone was on board, everyone was very keen to reduce these figures and push the department forward. So as it stands, we have negotiated with radiology 2 CT scans and 2 ultrasound scans, which we never thought would be possible, but they were very keen to help us, and all the consultants are very keen, and as are theatres, which we thought there'd be some resistance from, but I think it actually helps them out as well, because it prevents patients, wanting their surgery late at night, which we're not keen to do for various reasons. So generally speaking, everyone was very on board with the plan. We're currently writing a standard operating procedure protocol, which neither of us have had very much experience on, but we're very lucky to have a lot of help and support from the QI team and various other people that work in quality improvement. So we're very grateful for that, and hopefully next week it's going to go out to all the stakeholders. I'm sure it'll need some amending, but we're hoping to launch the project on the first week of March.
That's it. Thank you.